Good afternoon. Good morning to those of you on the West Coast, and welcome to today's webinar. We will be introducing the CAHPS Emergency Department Survey, or ED-CAHPS. This is a webcast presented by the Agency for Healthcare Research and Quality, CAHPS User Network. Before we begin, just a few of the standard housekeeping details. If you're having difficulty hearing the audio from your computer speakers, you can change the audio selection so that WebEx can call you and you can connect through your telephone instead. In the event that your computer freezes during the presentation, you can try logging out and logging back into the webcast to refresh the page. Remember also that you may just be experiencing a lag in the advancement of slides due to your internet connection speed. If you need help at any time during this webcast, please use the Q&A icon, and we will talk about that on our next slide. At any point through today's presentation, if you have any technical difficulties or if you have any questions for our speakers, you may ask a question through the Q&A feature. Depending on the browser that you're using, your WebEx screen may look a little bit different than what you're seeing on this slide, but look for the Q&A icon. It should be at the bottom right-hand side of your screen, and be sure that the drop-down option displays all panelists so that you can ask a question to our team. Feel free to share your name and/or your organization or the role that you play when you type in your question. Today's session is being recorded, and a replay of today's webcast, as well as the slides, will be made available on the AHRQ website. I'd like to welcome and introduce you to the speakers that we have for today. First, we have Dr. Karen Ginsberg. Dr. Ginsberg directs the Agency for Healthcare Research and Quality's work on the Consumer Assessment of Healthcare Providers and Systems, or CAHPS, as well as the surveys on patient safety culture. As an anthropologist and a demographer, Dr. Ginsberg has broad-based experience in patient experience, patient safety, and public health. In her position at AHRQ, she focuses on program development, implementation, operations, and evaluation, with a specialty in survey design and development and qualitative evaluation and assessment. We're delighted to introduce Dr. Karen Ginsberg, as well as our representatives from the Centers for Medicare and Medicaid Services and RAND. You will also be hearing from Layla Parast, who is a senior statistician at the RAND Corporation and is the project leader for the national implementation of the Emergency Department Patient Experience of Care Discharged to Community Survey Project. Kirsten Becker will follow Layla and is the director of the RAND Survey Research Group. She is the co-project leader for the national implementation of the Emergency Department Patient Experience of Care Discharged to Community Survey Project. And finally, you'll be hearing from William Lehrman, a social science research analyst at CMS, where he serves as the government task leader of the Emergency Department CAHPS Survey, as well as the Hospital CAHPS Survey. I'm Stephanie Fry, and I will serve as your moderator for today's call. Our focus today will be to give you an overview of the AHRQ CAHPS program, to introduce you to the ED-CAHPS survey, provide an overview of the ED-CAHPS survey administration, as well as a description of the survey analysis for the ED-CAHPS. We will review many of the resources that are available to you to support your use and implementation of ED-CAHPS, and we hope to have lots of time at the end to provide answers to any questions that you may have. With that, I will turn it over to Dr. Karen Ginsberg to take us from here.
Thank you, Stephanie. Good morning, good afternoon to everyone. Thank you for joining this webcast. I wanted to start today by telling you a little bit about the AHRQ CAHPS program and to tell you a little bit about how AHRQ and CMS worked together on the ED-CAHPS survey. CMS, of course, taking the lead, but AHRQ serving as in a supportive role about making sure that the survey could become a CAHPS trademark survey. So to start today by telling you about AHRQ, my agency, I wanted to tell you that we're a science-based agency, and as such, we invest in research and evidence to make healthcare safer and improve healthcare quality. We create tools for healthcare professionals to use to improve care for their patients. And we generate measures and data that are used by providers and policymakers and researchers to monitor and evaluate the progress of the U.S. healthcare system. And we feel very importantly that we need to get our tools and our products out to you, our users, in other words, to get our science to implementation. Can I have the next slide, please? So AHRQ has a well-established CAHPS program. CAHPS stands for, by the way, Consumer Assessment of Healthcare Providers and Systems. And this program advances the understanding and the measurement and improvement of patients' experiences with their health care. It was initiated and funded by AHRQ in 1995, and I have to tell you that we are actually celebrating our 25th anniversary this week. I think it's the original date of the establishment of the program was October 5th, 25 years ago. So this is a very big year and a very big week for us. We'll have something on our website to commemorate. So if you can find the website, look for our 25th anniversary timeline. So you'll hear about the CAHPS Consortium. The CAHPS Consortium is the group that oversees the program, and it's staffed by the AHRQ CAHPS staff. Our two cooperative agreements that we fund, Yale University School of Public Health, RAND Corporation, and our contractor, WestStat. Next slide, please. So I want to tell you a little bit more about our research and products. We have an active research agenda that focuses on understanding patient experience and how to measure it, in addition to the work that we're most known for, which is developing surveys on patient experience of care. And we also conduct research on best methods to implement surveys. And while historically we haven't made this research an end product for our users in and of itself, this work is becoming more critical to our stakeholders. And so we started an initiative here in the CAHPS program to better explain the work that's been done in this area. Next slide, please. So our priorities, our research priorities are patients' experiences with care coordination and shared decision-making, patient engagement, patient safety, collecting patient experience data using narrative protocols for the purpose of facilitating quality improvement, and then, as I just mentioned, the effectiveness of different survey administration modes for collecting CAHPS data. Next slide. And just a final couple of words on the CAHPS surveys themselves. These surveys are the gold standard for patient experience measurement, and that's because they capture the patient's voice in the development and testing of the surveys. They measure patient experience of care in different settings, and we work very closely with stakeholders to make sure that the surveys are relevant to those settings. The surveys are developed using standardized methodology and research findings, and CAHPS surveys are trademarked. The trademark is held by AHRQ, and all surveys have to adhere to the CAHPS design principles to earn that trademark. So the AHRQ CAHPS program worked closely with CMS towards the goal of being able to call this survey the ED CAHPS survey, bona fide CAHPS survey, and this means that they've used the CAHPS design principles and standards to create the survey. So we're very proud and excited that this survey is now part of the CAHPS family of surveys, and we look forward to its use to improve patient experience in the emergency setting. So thank you so much again for attending. Layla, I'm going to turn this program over to you.
Hi, everyone. I'm Layla Perez, and thank you so much for joining. I'm very happy to be introducing the ED CAHPS survey today. So first, I would just like to acknowledge our ED CAHPS research team. Beyond those that are on the call today, we have several people from the RAND Corporation and from Health Services Advisory Group and from CMS that made all of this possible. So just a little bit of background about the emergency department setting. As I'm sure all of us know, emergency department visits are very common. Nationwide, there are over 130 million ED visits annually. which is about 42 visits per 100 persons per year. Most patients walk into the ED, and by that I mean they bring themselves to the ED or have a family member or friend bring them. Only about 15% arrive by ambulance. Some common reasons for an ED visit, I won't read all of these, but stomach pain, abdominal pain, chest pain, cough, fever, shortness of breath, and throat symptoms are some of the common reasons. So the majority of ED patients are discharged to home. That's also sometimes referred to as discharged to community. And by discharge to home, we just mean, as opposed to being admitted to the hospital or an observation unit or some other facility. And so the discharge to home or discharge to community patient population is the eligible patient population for this survey. It's the focus of this survey. It's important to note that patients who are admitted to the hospital through the ED may be eligible for the hospital CAHPS survey, which is the inpatient survey, if you're familiar with that. So the purpose of the ED CAHPS survey is to measure the experiences with ED care of adult patients who are discharged home following their ED visit. While certainly many EDs have collected information on patient experience for their own internal use, this is the first national standardized survey of patients' perspectives of ED care. And our goal with this survey was to create common metrics and national standards for collecting and analyzing information about patient experience of care that could be adopted for quality improvement purposes. And the survey is available in the public domain at no cost. So the ED CAHPS survey is for voluntary use. The survey and recommended guidelines are available on the CMS website at no cost. And I'm going to read this website aloud. So it's available at https://www.cms.gov/research-statistics-data-and/systems/CAHPS/ED. Use of the ED CAHPS survey is voluntary. CMS is making the survey available for voluntary use. I'm saying that repeatedly because I recognize that will be a question that comes up a lot. And there are no plans at this time to collect ED CAHPS survey data through a central database. So a little bit about survey development. The survey was originally called the Emergency Department Patient Experience of Care Discharged to Community Survey, the EDPEC DTC survey. So if you go to that website that I mentioned, or Bill will be referencing some peer-reviewed publications that are publicly available, you'll notice that there is reference to the EDPEC DTC survey, sometimes just the EDPEC survey, and that's just the previous versions of this survey. Development began in 2012, so we've been working diligently on this for the past 8 years. And the ED CAHPS survey originally and still now parallels several aspects of the hospital CAHPS survey, the inpatient survey that I mentioned earlier. And part of the development process was submitting the survey for consideration for the CAHPS trademark, which we did receive in March of 2020. And at that time, it was renamed the ED CAHPS survey. So some key development activities included literature reviews. We did reviews on several different topics from 2012 to 2018. At the very beginning in 2012, we had a Federal Register call for topic areas. In 2012 and 2013, we conducted focus groups, specifically 5 focus groups conducted in 2 locations with racially, ethnically, and socioeconomically diverse patients. We've had multiple technical expert panels in 2012, 2017, 2018, and 2019 with healthcare providers and survey users and survey methodologists. Originally and throughout, the panels focused on survey content and survey development, but we also did have several TEPs that focused on survey administration. We conducted multiple rounds of cognitive testing of potential survey items in 2012, 2016, 2017, 2018, and 2019. Testing was conducted in both English and Spanish and was focused on refining item wording and response options. We also conducted 4 large-scale field experiments. The first was in 2014. That was our field test conducted among 12 hospitals across the country. In 2016, we conducted 2 experiments, one which was among 50 hospitals nationwide, and a second which was only among 8 hospitals, and that one was focused on testing novel survey administration modes. And our 4th experiment in 2018 was conducted among 16 hospitals to further test these some web-based modes in particular. And these experiments throughout gave us the opportunity to examine not just modes of administration, but also item performance and to look at the psychometric properties of items and form composites, which I will talk about a little bit later. And throughout, we had ongoing meetings with the CAHPS instrument team and CAHPS consortium to ensure that the survey aligned with CAHPS principles. So a little bit about survey content. The survey includes 35 questions. The topics are going to the emergency room, during this emergency room visit, people who took care of you, leaving the emergency room, overall experience, your health care, and about you. The about you section has questions, for example, about the patient's education, the language spoken at home, whether they're having someone assist them fill out the survey. So some of the items from this section are used for case mix adjustment. I will also talk about that later. You'll notice here, and I'll point it out in the next slide too, that within the survey, we use the phrase emergency room, not emergency department. Even though the survey is called the Emergency Department CAHPS Survey, emergency room is more well understood by the public, so that is what's used throughout the survey, and we do not abbreviate as ER anywhere. So here's a little snapshot just to see the first handful of questions on the survey. This is the male version of the survey. So a few things to point out. You'll notice, for example, in items questions 4, 5, and 6, that we do reference a specific ED visit, and that specific ED visit is identified in the cover letter that comes with the survey, so specifically saying during this emergency room visit. We have these clear section headings, the 2-column style formatting, CAHPS style wording, and again want to point out that you can see here we do use emergency room in the headings and in all the question wordings, and do not abbreviate as ER anywhere. So I'm happy to now turn it over to Kirsten Becker to talk a little bit about survey administration.
Hi, thank you, Layla. Hello, everyone, and again, welcome. I'm going to be talking about survey administration and our recommendations for survey sampling and mode of administration. All right. So as Layla mentioned, the ED CAHPS survey is intended for adult ED patients. So we define those as patients who are 18 and older. And we're talking about patients who are discharged home as opposed to patients admitted to the hospital or those discharged to care at other types of facilities. So the flip side of that is displayed on this slide. These are the patients that we would consider ineligible for the CAHPS Discharged to Community survey. Those would be patients who are age 17 or younger, who are not discharged home, so again, some sort of facility-type care, for example. Those admitted to the hospital from the ED. And again, I'd just like to note that these patients might be eligible for selection for the HCAHPS or hospital CAHPS survey, and we would like to minimize patients receiving two different surveys about the same visit in their mind. The remaining categories here are largely due to restrictions on or difficulty contacting patients in a timely fashion. The other patients that would be considered ineligible would be those who left without being seen and did not receive a billing code, patients who were deceased in the ED, those who requested not to be contacted, patients who are court or law enforcement patients, prisoners who are incarcerated at the time of their treatment episode, those who have a foreign home address, that would be a non-U.S. or non-U.S. territory home address, and those who might be excluded because of other local state regulations that place restrictions on who may or may not be contacted for research. So our recommended approach to sampling is to use simple random sampling, and to assume that patients are eligible unless there's positive evidence of ineligibility. This is the same as the recommendations or requirements for the HCAHPS survey. An example of this might be if at the time of sampling a discharge code or discharge location is unavailable, that one would assume that the patient would be eligible for the survey and to include them in the simple random sampling process. We also recommend deduplication within a calendar month. Some patients visit the ED multiple times, sometimes over a short period of time, so we are recommending that only one visit per month could be sampled. I do want to note that for our experiments, deduplication was at the person and not the household level. This is both for ease and because it was evaluated as a low burden if two individuals were sampled at the household level for two different visits. So one other note here, and Layla mentioned it when she was speaking, is that post-sampling we do recommend allowance of the use of a proxy for survey completion. Okay, I'd like to talk a little bit about the timing that we recommend for actually administering the survey. We suggest that we use 48 hours as a minimum to allow the patient to settle in post-discharge and allow the immediate emergency that brought them to the ED to subside. As we will discuss on the next slide, we did do some testing of on-site survey distribution at discharge, and we don't recommend proceeding with that for the CAHPS survey. We also suggest that we use 35 days as a maximum window for initial survey attempt. For the data collection window, we suggest that data collection activities should be closed out for any sampled patient by 35 days following the first contact attempt. Part of this is that for ED patients, we do highly recommend that surveying as soon as possible post-visit is ideal, but not less than 48 hours. All right, so let me talk a little bit about the testing that we've done. As Layla mentioned, we've done 4 large-scale experiments that have informed our recommended mode protocols. We tested mail-only, telephone-only, protocols. We also tested protocols that were web only. Those were email and a paper invitation to a web survey. We did testing of in-person survey distribution in the ED at the time of discharge. And then we also experimented with the different methods of invitation to a web survey. I mentioned an email invitation and a paper invitation. We also tried out the use of QR codes and of texting a link to a survey. And then many mixed mode variations of these things put together. So I'll note that our web-only options saw very low response rates, and I'm talking under 10%. The same was true for our in-ED paper distribution. We saw low response. It also led to some targeted respondent selection. Staff were less likely to distribute a survey to patients who were being discharged at the time when the ED was very busy, or patients who were perceived to have a negative experience. Staff were less likely to make the survey available to them at the time of discharge. Our mail-only surveys had only slightly improved response rates over and above the web-only and in-ED survey options. And generally, mail survey options, and this has been a trend for many surveys, tend to see some older and whiter, less diverse respondents. Our modes that involved phone had higher response rates and more diverse respondents. And there's so many experiments that I just can't possibly go into all the results here, but towards the end of this presentation, Bill is going to share a list of publications that have a lot more details on the findings of these experiments if you're interested in looking into the details of the different mode combinations and the particulars of the response rates. That'll be displayed at the end of this talk. So, all recommended modes at this time are mixed mode and include and conclude with a telephone component. The recommended protocols are all sequenced rather than simultaneous and tend to progress from the least expensive to the most expensive mode of administration. Mixed modes, we believe, are necessary to capture a representative sample of ED patients, especially younger male and minority patients. So the three recommended mode protocols are a standard mixed mode, that's mail followed by telephone, a web followed by telephone mode, and then a web followed by mail followed by telephone mode. And I'm going to take a look at each of those three protocols in just a second. We would like to note that this is the first CAHPS survey with a recommended web-based mode. Okay, so first, the standard mixed mode. This might be more familiar to some people. This is a mail followed by telephone with an initial attempt 48 hours to 35 days post-discharge, with the mailed effort followed up by phone starting on day 22 after that initial mailed survey. For all of the times where I talk about phone, we are suggesting up to 5 phone attempts over a minimum of 8 days, with attempts varied by day of the week and time of day to ensure calls are made on both weekdays and weekends, during the day and in the evening hours. Okay, so that's the standard mixed mode. The web telephone mode, we recommend an initial attempt with an emailed link to a web survey, followed by 2 reminder emails sent on day 2 and day 4 after initial email invitation. Reminders should only be sent to non-responders to date at the time the reminders are sent. We do not recommend sending reminders to all sampled individuals. Better to weed out those who have already responded. And then after the day 2 and day 4 reminders, We suggest beginning phone follow-up starting on day 6. Okay. The final recommended mode is our 3-pronged web, mail, and telephone survey. Again, this would be an initial attempt by email with a link to a web survey, followed by 2 reminder emails on days 2 and 4 to non-responders, followed by a hard copy mailed survey sent on day 6 from the initial attempt, and then finally followed to non-responders by phone starting on day 22 from initial attempt. And we found the benefit of this 3-pronged mixed mode is that this is the mode that saw the highest response rate and the greatest patient representativeness. Okay, this is just another snapshot here. On the left side, we see an image of 1 column of the traditional 2-column CAHPS mailed survey format. And the right side shows item 3 on a mobile-optimized web survey with a single item per page. So in this style, you can see that the response options are presented vertically, just like the paper format, but we have the back and next navigation buttons at the bottom of the screen. There are a lot of things to consider when designing a web survey, and we've provided a style guide on our recommended guidelines document that Layla mentioned earlier. It's available at the CMS website, and again, it'll be repeated at the end. We'll share that website a lot. There we include recommendations for web survey layout, appropriate fonts and colors to use of images, and the use and placement of navigation buttons. These recommendations and guidelines are based on survey research best practice, literature reviews of those publications, expert input, and survey respondent informant interviews that were done throughout the project. The versions that we tested on the web followed these guidelines, and our testing version was mobile optimized. And just a note that eye tracking testing was just recently completed, and analysis there is forthcoming. All right, and that wraps up my section. I'm going to pass it back to Layla for a presentation of the analysis of the CAHPS survey data.
Thank you, Kirsten. Okay, so a little bit about analysis. There are 2 recommended options for scoring items from the CAHPS survey, linear mean scoring and top box scoring. So linear mean scoring, if you're not familiar with it, is one in which response options are rescaled from 0, the worst response option, to 100, the best response option, with equal intervals between each option. So to give an example, for the item, before giving you medicine, did the doctors and nurses tell you what the medicine was for? For that item, the response options are yes, definitely, yes, somewhat, and no. And with linear mean scoring, yes, definitely is scored as 100, yes, somewhat is scored as 50, and no is scored as 0. In contrast, with top box scoring, only the most positive response option or options in one example that I will talk about is coded as 100, and all other response options are coded as 0. So again, for the same item, with top box scoring, the yes definitely would be scored as 100, the yes somewhat would be 0, and the no would be 0. So linear mean scoring is sometimes preferred because you kind of get partial credit, essentially, for those intermediate response options. But consumers often prefer top box scoring because of ease of interpretation. With top box scoring, you can take the overall score for an item and interpret that as X% of patients said yes, definitely to this item, whereas you can't use that interpretation with linear mean scoring. So this is another example where the response scale is a frequency scale. So the item is, during this emergency room visit, how often did nurses explain things in a way you could understand? The response options are never, sometimes, usually, and always. With linear mean scoring, the never is scored as 0, the sometimes is 33.3, the usually is 66.7, and always is scored as 100. So again, it's taking those response options, scaling them from 0 to 100 with equal intervals between each response option. With top box scoring, with this response scale, a never would be 0, a sometimes would be 0, usually would be 0, and always would be 100. So only the always gets 100 points. And this is another example for an item that has a 0 to 10 response scale. So this is the only item where it's the top 2 response options that are considered the top box. So this item is using any number from 0 to 10, where 0 is the worst emergency room care possible and 10 is the best emergency room care possible. What number would you use to rate your care during this emergency room visit? With linear mean scoring, a 0 is scored as 0, a 1 is 10, 2 is 20, and so on. 9 is 90, and 10 is 100. So again, equal spacing between each of the response options from 0 to 100. With top box scoring, everything except for 9 and 10 would be 0 points. And a response of 9 or 10 would both be 100 points. So again, this is the only item where it's the top 2 response options that are considered the top box. Okay, so as I mentioned when we were talking about development, throughout our development we had the opportunity to analyze data from our experiments and to conduct psychometric analyses to inform, to look at the performance of our items and to inform the development of measures. And so we have 6 measures, 4 composite measures, and 2 global measures. So I'll go through each one and give an example from each one. Getting timely care is our first composite measure. An example from this composite is, during this emergency room visit, did you get care within 30 minutes of getting to the emergency room? With response options yes or no. Our second composite measure is how well doctors and nurses communicate. An example from this composite is, during this emergency room visit, how often did nurses explain things in a way you could understand? And the response options here are never, sometimes, usually, and always. And you'll note throughout that we have various response scales. A major goal of our cognitive testing throughout the years was to understand and identify the appropriate response scale for each item. Okay, our third composite measure is communication about medication. An example from this one is, before giving you medicine, did the doctors or nurses tell you what the medicine was for? With response options, yes, definitely, yes, somewhat, and no. And our fourth composite measure is communication about follow-up. An example from this composite is, before you left the emergency room, did a doctor, nurse, or other staff talk with you about follow-up care? With response options, yes, definitely, yes, somewhat, and no. Our 2 global measures are overall ED rating and willingness to recommend the ED. The overall ED rating is using any number from 0 to 10, where 0 is the worst emergency room care possible and 10 is the best emergency room care possible. What number would you use to rate your care during this emergency room visit? And for willingness to recommend the ED, would you recommend this emergency room to your friends and family? With response options, definitely no, probably yes, and definitely yes. Okay, so a little bit about case mix adjustment. If you're familiar with other CAHPS surveys, you might be familiar with case mix adjustment, also commonly referred to as patient mix adjustment. So if EDs are to be compared to each other, or even if you were just conducting the survey in your own ED, but you plan to compare over time and you expect your patient population might change over time, case mix adjustment is strongly recommended. We have had the opportunity from all of our experiments, again, to throughout the years look at case mix adjustment and develop and refine our case mix adjustment model. So based on all of those analyses, at a minimum, we recommend to adjust for patient age, patient education, patient self-rated health status, language spoken at home, reason for the ED visit, whether the patient was taken to the ED in an ambulance, whether the patient had proxy assistance, and response percentile. Most of these, or all of these, with the exception of patient age and response percentile, come from the survey itself. So patient education, self-rated health status, whether they came in an ambulance. Patient age comes from the hospital administrative file, and response percentile is defined as it is in the hospital CAHPS survey, and basically reflects, it's a function of lag time, the time from discharge to survey response. There are more details about case mix adjustment in the guidelines that are on the website that we provided. Bill will also give a reference. One of our papers that's in medical care goes through all of the details of our case mix adjustment analyses if you're interested in that. Another important point about adjustment is that while Kirsten did mention there are 3 recommended protocols for survey administration, there are no mode adjusters available. We do expect, based on some previous analyses, that there would be mode effects. So we urge caution if you are trying to compare EDs that use different mode protocols. And I will now turn it over to Bill Lehrman to talk about available ED-CAHPS survey resources.
And once again, we'd like to express our appreciation for all the members of the audience who are taking time out of their busy day to learn about our new ED-CAHPS survey. I'd also like to say that we're very grateful for the CAHPS Consortium for reviewing our survey and bestowing the CAHPS trademark on it, and also to our partner in HHS, AHRQ, for putting on this webinar for us. Next slide, please. I'd like to say a few words about the benefits of using the ED-CAHPS survey. As we've said already, this is a chance for EDs to collect data from their patients about the ED experience. It provides a standardized method to calculate, measure scores, and then to identify aspects of care which most need improvement. As we've indicated, either directly or indirectly, the ED-CAHPS survey was rigorously developed, extensively tested, and it's a standardized survey instrument that enables EDs to gather key information about their patients' experience of care. We've included very detailed implementation protocols. We explain in great detail how we recommend that scoring be done. And most importantly, all this information is in the public domain. In other words, it is free to use. Let me also reiterate that CMS is making the ED-CAHPS survey available for EDs to use on a voluntary basis. CMS has no plans at this time for national implementation, collection of data, or public reporting of data from the ED-CAHPS survey. CMS is making the survey available for EDs to use on a voluntary basis to better understand their patients' experience of care and to help EDs develop quality improvement efforts in areas in which they see the need to improve the care experience. The CMS has a website on which we post all the information about the EDCAPS survey. We also have an email mailbox if you have questions about the EDCAPS survey and how to use it. So we will be happy to take those questions, of course, at the end of this presentation, and also if you mail them to our EDCAPS mailbox, the address will be provided a bit later. Okay, so the EDCAPS survey examines specific areas and aspects of the process of care in the ED as experienced by those patients. Layla and Kirsten have mentioned that we've done a number of field tests for the survey in the development of the survey, and we learned something about patient experience in the EDs. First of all, it's important to mention that patients' experience is not uniform. It varies quite a bit across EDs and also across certain patient categories or certain patient characteristics. For instance, our large-scale field study, which included 50 hospitals and over 16,000 patients, indicated some interesting findings about ED experience. Female ED patients reported significantly poorer ED experiences than men. Females experience longer wait times and poor communication with ED staff, specifically with regard to information about test results and about follow-up care. Another study found that minority patients also differed in experience than white patients. We found that minority patients experience greater utilization of the ED. They went there more often because they more often did not have a usual source of medical care. Minority patients also provided better overall rating and better communication with the staff, especially with regard to follow-up care. So we found that the minority patients answered the survey differently. We theorized that perhaps because of the greater utilization and less frequently having a usual source of care, minority patients compared to white patients perhaps a greater familiarization with the ED and therefore perhaps more realistic expectations about the care in the ED and how it was delivered. And I'll mention some papers later that we have published and which we hope to publish, which will go into these results in more detail. Anyway, to reiterate, the EDCAPS survey can help EDs target quality improvement efforts. They can help EDs to track change in experience over time. And if they implement ED-QI efforts, quality improvement efforts, it gives them a metric by which to judge whether those QI efforts are actually working. And as Layla mentioned, if, say, perhaps a system of hospitals that have EDs implement the EDCAPS survey, they may want to adjust for different patient mixes in the different EDs within their system. Next slide, please. Okay, as promised, here's a list of the available EDCAPS survey documentation. And these materials are available on our CMS website, which Layla articulated earlier in this presentation. Available on our website are the actual EDCAPS survey instruments in both English and Spanish. Also, recommended guidelines, that is our manual for how to implement the survey. In the HCAHPS world, we call these the quality assurance guidelines. In the EDCAPS world, we call these the recommended guidelines. And in fact, let me just reiterate a point we've made maybe too subtly at times. Everything we're saying today about implementing the EDCAPS survey are recommendations. They're not requirements because the survey is not required. But they are our recommendations that are based upon extensive testing of the survey and conformance with the best survey implementation practices in the CAHPS world. But they are recommendations, not requirements. Okay, we also put together a nice little fact sheet about the EDCAPS survey and a document in which we answer frequently asked questions about the survey. And as has been explained earlier, when we began this project way back in 2012, the name we gave to the survey was the ED Patient Experience of Care Survey, or EDPEC. So a lot of our historical documentation refers to EDPEC rather than ED CAHPS. We just received the ED CAHPS name this year. But we present historical versions of the survey on our CMS ED CAHPS website in case people want to know exactly what was asked in the earlier testing of the survey. And I would be remiss if I didn't mention that AHRQ has its own lovely website with a CAHPS Emergency Department survey page on it, with more information about the survey and also links to the information on the CMS ED CAHPS page. Next slide, please. And here's the list of available publications, some of which we have alluded to. The first one's about push-to-web mixed mode approaches to surveys, which provides information about how we got people to use, or how we try to get people to use the web version of the survey. Another paper is about improving response rates in the ED setting, and another paper about the national testing of the ED survey. So these published manuscripts are available. You see the citations here. We also have plans to publish other research findings, such as those about gender and race ethnicity differences that I mentioned earlier. We've also done geocoding of ED patients to find out how far they traveled to go to the ED they visited, and whether there are certain characteristics of patients who travel long distances or short distances to go to an ED. So we hope to have those manuscripts published soon, and we will let you know on our CMS website when they are available. Okay, and with that, I will pass this back to Stephanie for our Q&A session.
Thank you so much, Bill. And now we are going to move into the Q&A portion, and I know we have a number of questions already queued up, so we'll get through as many of those as we can in our remaining time. As a reminder, you can type a question into the Q&A box. Look for the Q&A icon on the bottom right-hand side of your screen, and be sure that the drop-down option displays all panelists so our team can see it. And again, feel free to share your name and or organization or role when you type your question. Depending on the browser that you're using, your WebEx screen may look slightly different from what you see on this slide, but do just look for that Q&A icon. So moving into our questions, the first one that we have seen the most of is, will these slides be available? And the answer is yes. Both a replay of today's webcast as well as the slides will be available later on the AHRQ website. And as Bill mentioned, there is also content on the AHRQ website that has a brief description of the survey as well as a link to the CMS site. So that will be a great resource for people who are looking to direct colleagues or to seek further information. The next question in my list, Layla, I will cue you for this one. Is the survey intended for any kind of ED?
Sure, I'm happy to answer that. So all of our development and testing was done within hospital-based EDs only, but the survey can certainly also provide valuable information to other EDs like standalone EDs.
Thank you. And Layla, if you don't mind, I'll keep you on the spot. How many patients should be sampled, or how many completed surveys should be targeted? And as a follow-on, what if someone has a very small ED, for example, too small to reach the recommended number of surveys? What are the recommendations in that case?
Yeah, that's a good question. And it's kind of a complicated answer. So if EDs are going to be compared, we do have recommendations, and these are in the guidelines that we have referenced repeatedly, on the number of completed surveys that are recommended to achieve acceptable levels of reliability. So those numbers are 375 completed surveys if linear mean scoring is being used, or 450 completed surveys if top box scoring is to be used. And those are different because reliability is different depending on what scoring algorithm is used. Now, if you're not comparing EDs, then you might not care as much about reliability with respect to, comparisons because you're not comparing. And in that case, it's a little bit trickier and it's specific to your ED. So again, it will depend if you're going to be doing linear mean scoring or top box scoring. If you're doing linear mean scoring, it depends on the expected variation of scores within your hospital, within your ED. So if you have conducted, for example, a previous survey that possibly has a similar question or some similar questions to the CAHPS survey, and you can use that kind of like pilot data to get an estimate of your variance, that can be helpful in determining what sample size you need. But it also really depends on what you're going to use the survey for. So if you're, a small ED and you just, you want to conduct the survey over a 3-month period, are you trying to use the survey to identify your lowest performing kind of domain of care? Are you trying to identify areas for quality improvement? Are you trying to calculate some measure scores now, implement some kind of quality improvement program, and then measure again in 1 year, in which case you want to make sure you have a big enough sample to detect change? Are you going to try to look at disparities? Like, Bill said, we have some papers that are kind of in progress that look at males versus females, that look at race, ethnicity. It depends on the size of your subgroups in that case. So a lot of factors go into answering that question if it's just collecting the data for a single ED. But to give an example, if you were, let's say, going to use top box scoring and just think about a single item, and let's say the true score for your hospital for this item is, 50% using the top box scoring. A sample size of 100 completed surveys would give you a standard error of 5%. Whether that's the standard error that you want, again, depends on what you're going to use it for, depends on the level of precision that you're looking for. A sample size of 300 completed surveys would give you a smaller standard error of 2.9%. If your true score is more like 90%, those same sample sizes will give you a smaller standard error. So again, if you're comparing, we do have specific guidelines on sample size that are in the guidelines document and are based on all of our previously collected data. If you're not trying to compare between EDs, then it depends on many factors, including variation, the expected score, your desired margin of error, and what you're using the results for.
Thank you, Leila. And because you talked so much just now about scoring and different uses of that, I wanted to just meander to a nearby topic. Somebody was asking how you can compare EDs that use the linear mean scoring methodology to those that use top box scoring methodology. And I wondered if you could just say a little something about whether it would be appropriate to compare across those two methodologies.
Sure. I don't think it would be appropriate to compare two different EDs that are using two different scoring approaches. It really is not a fair comparison. Throughout all of our experiments, we've actually we've scored everything in all of, because, we were doing extensive analyses using both linear mean scoring and top box scoring. My understanding is there are other CAHPS surveys that do score items and measures in both ways and use them differently, maybe one for public reporting because, again, consumers often prefer top box scoring, but linear mean scoring for some other purpose. So that, I would not recommend comparing two EDs that use two different scoring approaches.
Thank you. And then, again, another piece that you touched on, and I just wanted to ask specifically, if someone is conducting the survey in a single ED, do they really need to worry about case mix adjustment?
Generally speaking, no. So if you aren't comparing to another ED, you don't need case mix adjustment. As I mentioned, the exception to that is if you're comparing over time and you think the mix of patients within your own ED might change over time, then you may need to consider it. But generally, if you're just doing the survey in the next 1 or 3 month period, and you're calculating the measure scores, you don't need to worry about case mix adjustment.
Great, thank you. And Kirsten, I'm going to let Layla off the hot seat and pivot over to you for a moment, if you would. And can you say a little bit about why 35 days for each contact window, or the time from discharge to first contact and time from first contact to the end of the first survey field period? Can you just say a little bit more about that, please?
Sure. Well, really, my answer is the same, both for the why 35 days max from discharge to first survey attempt and why 35 days from first survey attempt to closing out the survey. Our experiment results really showed that the earlier patients are contacted after discharge, the more likely they are to respond. And additionally, with the use of web modes and modes involving phone, patients are able to complete the survey sooner compared to, say, a mail-only component. So we would like to encourage EDs to try to collect the survey data, as soon as possible, not within 48 hours of discharge, but as soon as possible after that. So that's why our recommendation.
Great, thank you. And wondering if you can, Kirsten, just say a little bit about where people can look for results from the feasibility test and the mode experiments.
Sure. I am not sure if I have control of the slides at this moment, but I would recommend the first of the papers that are listed on the slide that Bill walks through. Yes, all of these have results from all of our experiments, but if you are particularly interested in some of the web-based experimentation or the mixed mode experimentation, those results are in the first of these papers. And then if you're talking about the more traditional modes and the larger mode experiment that we did with 50 hospitals, those results would be on that third bullet there that talk a little bit more largely about the earlier experimentation. So I think there's lots of good data out there, and I'll also say that the primary link we've been talking about on the CMS page also does have links to our papers.
Great. Thank you so much. And just as a reminder to folks, all of these resources will become available on the AHRQ website. So the links that you see up on your screen, we will make those available to you so you can access all of those pieces of documentation. And Bill, I was wondering if I could go over to you and ask, will this survey be mandated, and if so, when?
Thanks, Stephanie. No. At this time, CMS has no plans to mandate the survey. We are making it available for voluntary use by EDs to help them in their quality improvement efforts. But there are no plans at this time to mandate or implement or require the CAHPS survey.
Thank you. And we have a couple of questions about inclusion of individuals with homelessness. And so Layla or Kirsten, I'm not sure if one of you are the best to answer that, but would such individuals be eligible for the survey? And if there's a patient being discharged into homelessness with no discharge plan, how would you advise on a survey collection under those circumstances?
This is Kirsten. I will start, and if somebody else from the team wants to chime in, feel free. Our experience across hospitals was that there was not a great and reliable way to identify homeless patients. Different hospitals had different approaches. Some just considered patients homeless if there was blank contact information, which our experience is that's not entirely true. And we discussed this extensively as well with our expert panel. Ultimately, we decided that there's not a reason for exclusion other than perhaps difficulty reaching them. However, all of our modes have a phone component, and 2 of the 3 have a web-based component. And our experience is that many homeless individuals do often have email that they check, and many also have cell phones. So we are not consciously excluding these patients at this time.
Thank you. And there's a few others. Stay tuned for a few other questions about eligibility. There was a question about, is a nursing home considered a home or a facility? So in terms of eligibility for this particular survey, how did you consider a nursing home?
This is Kirsten. I'll chime in again on that one. Yes. So eligible patients for this survey are those that are discharged home to their community location. So if a discharge code is a long-term care facility or other nursing-type facility, those patients we would recommend to be considered ineligible.
Thank you. And again, in the eligibility criteria, there were a couple of different questions that came in about patients being admitted to observation who actually remain outpatient and yet are admitted to the hospital. How do those fit into your eligibility criteria, please?
Yes. This is a tricky question. We had a lot of conversations about observation units, a lot of research about how they're treated. And we also included observation units in some of our cognitive testing with patients. Ultimately, we learned that patients are rarely able to distinguish an observation unit between their inpatient experience. Often if they are moved anywhere in the building, they believe they've been admitted. In other models, observation units are really just part of the emergency department, in which case patients don't understand that they've had a transition in care. So as such, if there is a discharge code from their emergency department visit to observation, we would consider those patients as ineligible for this study. Remember, we're talking about discharged home as an identifier based on their discharge status from their emergency department visit. So if there's a discharge code to observation, that would make them ineligible for this project. But it is a tricky subject.
Thank you. One more, and then we'll shift gears here, but a question from folks wondering if proxy responses are allowed.
This is Kirsten again. I will take that one, and then maybe Stephanie will move on, but that's okay. Yeah, the proxy responses are, we do suggest including them for this project. So once an individual has been sampled and survey invitation has been made, if they identify a proxy respondent to answer on their behalf, we suggest including those proxy respondents. You'll note if you take a look at the survey that we do include some questions about proxy response so that it is measurable and reportable.
Thank you, Kirsten. Sorry to keep you on the hot seat so long. Maybe I can trouble Layla. There's some question about the thinking around the deduplication and why that was done within a calendar month as opposed to a specified number of days.
Oh, Sorry, I was still muted. That actually might be a better question for Kirsten still, but that is, I think, consistent with other CAHPS surveys, and our sampling was done generally at the month level. So that is kind of what we implemented and what we recommended.
Yeah, different hospitals had different sample file submission schedules. Some do it in a very timely fashion. Others take a little longer to process their data. And so calendar months just worked logistically.
Mm-hmm. Great, thank you. And there's a couple of questions that have come in about the specific survey wording, and so it may be helpful to say a little bit about the testing, but a comment or a couple of comments about the "Did you receive care?" question, and in testing, did you find that that was ambiguous? How did that language come about?
So I can try to answer that. So we did extensively test that "get care" phrasing, and that was one that, gosh, we've talked about over the years, and worked with our TEPs to refine that item wording. I saw a comment about this. I did want to mention that our survey development TEP, survey content, we were grateful to have the opportunity to have almost always kind of the same TEP members for a few years throughout, so to help provide some feedback on items, and then we were able to test the items both in the experiments and cognitive testing, bring that back to our TEP and continue to refine. So that was an aspect of these many years of development that we're really grateful for. So this item was extensively tested, and we did find that people did generally understand the concept of "get care" and didn't just think about, getting care from a doctor, but it was generally and consistently well understood. Kirsten, I don't know if you have anything to add to that.
No, only to say that item had been flagged and discussed so many times, and it really was very interesting doing a lot of the cognitive testing, how well it was consistently understood. I remember one individual in particular who articulated it as they were doing something about my problem. People were addressing my issue, which I just always remember sort of stuck with me. They did include nursing care. They did include care from other types of providers besides besides physicians.
Thank you. And again, about the survey content, if you would, to what extent does the ED-CAHPS survey capture coordination between the ED and the patient's outpatient or non-ED providers?
Yeah, I can say something about that. So there are multiple questions about follow-up care and post-ED care. Let me just, well, there are 4 questions, so let me just quickly say them. Before you left the emergency room, did a doctor, nurse, or other staff talk with you about follow-up care? Did you need information about how to get follow-up care? And if yes, then did a doctor, nurse, or other staff give you information about how to get follow-up care? And before you left the emergency room, did a doctor, nurse, or other staff give you information about what symptoms or health problems to look out for at home? And those do inform that follow-up care, communication about follow-up care composite. So certainly that does not capture, did you make an appointment? If you needed follow-up care with this specific provider, did you make the appointment? Were you able to make the appointment? Did you go to the appointment? What happened? It certainly doesn't capture all of that, but we do try to capture it to the extent possible with those questions. And certainly, this is specifically stated in the guidelines that are posted online. If an ED was interested in other items around this topic, supplemental questions could be added to the survey. We do strongly recommend that they are only added at the end of the survey, and that, of course, you consider sensitivity to survey length. We did not include in the end any other questions beyond that on this topic.
Thank you for that. Bill, I think this one may be in your camp, and the question is, particularly because this testing was done in pre-COVID times, does CMS have any plans to do any additional testing or make any additional changes at this time?
Thanks, Stephanie. Yes, the testing was done, I think most recent was 2018. No, we don't have, CMS does not have plans at this time for further testing. It's something we can discuss, whether anything would be different now. But the short answer is no, we don't plan additional testing at this time.
Thank you. And a couple of questions about modes of administration. So during the development of the EDCAPS survey, what systems were used for email and text message survey invitations, as well as when you speak about telephone data collection, was it automated or was it an actual live person who called?
I'm not entirely sure that the technical systems or the specific software that was used is immediately relevant for the emailing, texting, the web survey platform, because any group that decides to use these materials that are being made publicly available will need to program up a survey in whatever software they already use. It's not as if the programming language is available. As for the telephone mode, everything was hand-dialed and live interviewer.
Great. Thank you so much for that. And Kirsten, if I could go back to a couple of questions for you. Can you share some insights on respondent diversity and inclusion efforts, mainly concerning adequate representation of minorities in the survey?
Sure. Our response rates, as you heard, for a lot of the single modes were on the low side, and as many survey efforts have seen in lots of different settings, there tends to be a slant towards older and female respondents. This is a primary driver of why we're recommending sequential mixed mode approaches and inclusion of the telephone component. Our inclusion of the telephone really helped us to draw in respondents who were younger, male, and who were of minority backgrounds. I can also say, I'm just pulling up some data here, that relative to web and mail, our phone respondents had the most similar age distribution to our sampled population, and that these results really back up what has been seen in other health survey settings, that the phone is able to draw in a different respondent mix than mail in particular. As I said, the younger folks, more male respondents, and also those who have poorer health status, who self-report lower quality of physical and mental health. So the phone mode just increases that likelihood, and I think especially in an environment where diversity and inclusion is critical, I think the inclusion of the phone mode helps us get there.
Thank you. And while on modes, there's a question about, are there any other technologies being considered for survey delivery or for data collection modes such as SMS or text messaging?
Well, yes. So the survey is really too long for an SMS survey. That's the style of survey where individual survey questions are texted and responses are collected through numeric text response. So this survey is just longer than a typical SMS-based survey would be. However, if you're talking about using text to deliver a web survey link, that is something that we tested. While it can definitely increase ability to reach patients and push folks to web, it does bring a host of other requirements and considerations like compliance with local regulations, compliance with TCPA, the Telephone Consumer Protection Act, a requirement for documentation of patient consent to text, and consideration of text fees that might be applied to patients based on their cell phone plan. So it's a lot of things to consider before using that approach for delivery of a survey invitation.
Perfect. Thank you so much. And I think we've got time for just a couple more questions. And Karen, I'm going to put one over to you, please, which is, are there any plans for a database that would allow comparisons across facilities that conduct the EDCAPS survey?
Thanks, Stephanie, for the question. And I think the reason why this is directed to me instead of CMS is because AHRQ does maintain some databases for surveys for voluntarily submitted data for surveys that aren't necessarily required for any kind of CMS program or accreditation program, and we've worked cooperatively with parts of CMS to establish databases for them, and so at this point we don't have plans, but we have not discussed the issue yet, and I'm happy we haven't discussed establishing a voluntarily reported database for emergency departments. I'm happy to entertain that conversation with CMS should they be interested in doing so.
Thank you so much. And I think we are nearing the end of our time. There are several additional questions about eligibility and inclusions and exclusions, and so I will try and get through one or two more of those so that people can have a clear understanding of survey administration, and then we will wrap up and try and respond to any further questions thereafter by email or if you contact us directly. So if you would, Kirsten and Layla, do you advise screening out any particular types of presenting patients, for example, victims of violence or any other types of exclusions?
Layla, I can take that if you like.
Okay, go ahead.
I would not recommend screening out any certain diagnoses. We don't consider primary reason for visit any sort of eligibility criteria. The wonderful thing about the ED is that people go there for all kinds of reasons, for all sorts of problems, and we really want to measure all patient experience.
Thank you so much. And one final one in inclusions and exclusions. How have you included or not those patients who leave against medical advice?
I will give that one a shot again. We did make the decision to exclude patients who leave against medical advice prior to receiving a diagnostic code. So if there is discharge code. If there's no billing code, no record of this person as an ED visitor, they wouldn't have even been included in the sample files that we received. However, if someone is seen by a doctor, they are treated, and they just leave against medical advice, that person would be included in the survey. There's kind of no reason not to include their experience of care. It is possible they might have left because of a negative experience, or it's possible they left, somebody had to go to work or had child care issues. So we do not advise sort of systematically excluding people who left without being seen, except those who don't ever even receive a billing code.
Mm-hmm. And this is Layla. I did just want to mention that in the guidelines that we keep referring to, it's a 102-page document, and it does go into these details, much more specifically. So we have a data file layout. We have discharge codes and say exactly what codes are eligible and not, ineligible. So definitely there's a lot more detail than what we can provide in 1 hour in those documents. So I'd really encourage anyone who's interested in that level of detail to look at that document.
Thank you so much to Kirsten and Layla and Bill and Karen, all of our panelists here today, for getting through an unbelievable number of questions. By way of wrap-up, I want to encourage you to sign up for email updates periodically. We send email announcements about CAHPS news, such as new webcasts, data submission timelines, and other products. You can sign up for email updates by going to the AHRQ website, clicking on the right-hand corner and choosing the email updates associated with CAHPS, or the Consumer Assessment of Healthcare Providers and Systems. You may contact the CAHPS User Network at any time. For example, if we haven't been able to get to your question today and after reviewing the materials you still have outstanding questions, please do reach out to us at any time. You can reach us via email at caps1@westat.com or by toll-free phone line at 1-800-492-9261. And you can access the CAHPS website at www.arc.gov/CAHPS. You can also reach out with questions or comments about the ED-CAHPS survey by emailing ed_survey@cms.hhs.gov or emailing today's speakers. William can be reached at william.lehrman@cms.hhs.gov. Layla can be reached at parast@rand.org, and Kirsten can be reached at becker@rand.org. Thank you so much for your time. A brief webcast evaluation will pop up when you close out from today's webcast. Please do take a moment to provide us with your feedback, as it helps us improve our offerings and plan for future events to make sure that they meet your needs. We invite you to visit the AHRQ website and contact us at any time by email or phone. Thank you again for joining us. That concludes today's presentation.